work to create a world
that's free of infectious diseases.
We work to make sure
that no infectious disease
is left unchallenged.
We discover, develop,
implement and evaluate
health solutions,
working alongside the most at-risk communities.
doing so ultimately builds
A healthier, safer world for everyone.
We are the Kirby Institute.
Thank you for joining us today for the Kirby Institute seminar series. My name is Professor Miles Davenport. I'd like to start by acknowledging the traditional custodians of the land on which we gather today and pay my respects to their elders past and present. I join you today from Gadigal land. I extend my respect to Aboriginal and Torres Strait Islander peoples joining us today. Some housekeeping to start off with. The format of the seminar will start off with presentations from each of our presenters, followed at the end by a joint Q&A session. You can ask questions throughout the presentations by clicking the Q&A icon at the bottom of the screen. You can also vote for questions that you'd like to see answered, so they move up the ranking. So today we're here to discuss monkeypox, which has arrived in Australia, and as many of you will have heard, local transmission in New South Wales has also been observed. Today we're here to discuss what we know about it, and the strategies that are urgently needed to curb its spread. While Australia has secured some vaccines that are thought to be effective against monkeypox, there's a shortage of supply and urgent questions around how this should be best distributed. Men who have sex with men are currently the most at-risk group for monkeypox. And so it's important that non-stigmatising and community-led prevention programs lead the way. Today, we have three speakers who will address different aspects of the current challenge, covering the history of the epidemic, what we know so far, how it may impact Australia, and how research in public health can help control this. Professor Raina MacIntyre is on the WHO SAGE, smallpox and monkeypox working group, and will give an overview of prevention and treatment of orthopoxviruses. Professor Andrew Grulich, a leader in Australia's response to HIV, will provide a description of the current epidemic in Australia and the available public health responses. Finally, Mr Heath Painter from AFAO will talk about the community response to monkeypox in Australia. So the Q&A is now open if people would like to use it, but it's my great pleasure to introduce our first speaker, Professor Raina MacIntyre from the Kirby Institute. She's a professor of global biosecurity and NHMRC principal research fellow and head of the biosecurity program at the Kirby Institute. She leads a research program in control and prevention of infectious diseases spanning vaccinology, pandemics and emerging infections, and personal protective equipment. Her area of vaccine expertise is vaccination of older adults and immunosuppressed people, as well as the role of influenza and other infections on triggering cardiovascular events. So I'll hand over to Raina.
Thank you, Miles. I'm coming to you from Gadigal country. I'm just going to give an overview of orthopoxviruses, and then Andrew and Heath can give a more deep dive into the current epidemic. These are my disclosures. I've been working in the field of orthopoxviruses for 15 years or so. So orthopoxviruses are part of a bigger group of viruses called pox viruses, and the genus orthopoxvirus includes a number of animal viruses, zoonotic viruses, occasionally infect humans, and the human-only virus, variola, which caused smallpox, and monkeypox is part of this genus. It's smallpox, which I'm going to tell you a bit about, is a very ancient virus, probably goes as far back as 1580 BC. In some work we did looking at how smallpox spread across the world from 1654 onwards, It spread from Europe to East Asia, then to South Asia, and that was kind of the big hotspot of infection from where it spread to other parts of the world. This smallpox can present as variola major and variola minor, also named called alastrum. The transmission is airborne. It's a respiratory virus, as is monkeypox, found in the respiratory tract. It's also spread by direct contact with infected bodily fluids, or can be re-aerosolized through bedding or clothing. If you shake a bed sheet or whatever, that's been well described. It's inactivated by standard disinfectants or ultraviolet light, and the same applies to monkeypox. But it can survive for years, even decades, in a protein matrix such as a scab if protected from light. The last naturally occurring case was in 1977, and eradication was declared in 1980. The only two places where there are known stocks of smallpox are at Vector in Russia and the CDC in the US. So smallpox had this phenomenon called aerial convection, which was noticed in the last 100 years before it was eradicated, because it was quite rare by then. This was in England, it was first noticed. So any unusual transmissions were noticeable. And we did some research pulling together all the data on aerial convection and found numerous reports of transmissions in distances of 1/2 mile to 3 miles. And the longest was in the Soviet Union, when the Soviets exploded a smallpox bomb on this island called Aralsk, and a ship passing by 15 kilometers away, somebody got infected. This is what the rash looks like. It's centrifugal, particularly affects the hands, palms, and soles, and that's similar to monkeypox. Whereas chickenpox, varicella, is more centripetal and doesn't tend to affect the palms and the soles. The incubation is 12 days for smallpox, and there's a prodrome, which lasts about 2 to 3 days, and then the rash first appears inside the mouth in the oral mucosa and pharynx, and then you get the rash on the face and forearms, and all the lesions are at the same stage of development. And it's infectious from the onset of the prodrome until the scabs fall off. There's 4 different types: ordinary smallpox, vaccine modified, which is quite mild, and then hemorrhagic types 1 and 2, which are tend to be fatal. The overall case fatality rate at the time of eradication was 30%, and most deaths occurred in the first week. In terms of the period of isolation, it's a must to isolate for the prodrome and the rash, and technically till the scabs fall off. The R0 of smallpox has been estimated by the US Public Health Service to be about 5, and in some of our research we estimate it to be about 4.6, but it could be higher. We don't really know, given contemporary levels of immunosuppression and lack of immunity, which are 2 different things. So we looked at both immunosuppression. At the time smallpox was eradicated in 1980, the first heart-lung transplant hadn't happened. There's a lot of advances in medicine since then, in cancer, autoimmune diseases, etc., and we've estimated about 17% of people in Australia, higher in the US, close to 20%, live with moderate to severe immunosuppression. So that, as well as residual vaccine immunity, are the key determinants of how severe a re-emergent smallpox epidemic would be. And those 2 things will make a difference to how severe it would be. So if you don't factor in those, you could underestimate the severity. We were fortunate enough to get some serum that had been tested for neutralizing antibodies to vaccinia, which is the vaccine virus. And basically, there's hardly any immunity to vaccinia in New South Wales. And this would also be relevant for monkeypox. And there's very little immunity in the population, pre-existing immunity. You can see in the right-hand graph that people over 50, some of them pass the protective threshold, but most don't. The word vaccine comes from the Latin of a cow, and it was coined in honour of Edward Jenner, who developed the arm-to-arm vaccination using cowpox, and that was later changed to horsepox in a technique called equination. And vaccines really had a huge impact on disease incidence and deaths from the time they were introduced to eradication. These are very highly effective vaccines. The effectiveness is about 95% in naive people and 98% in people who've been previously vaccinated, and very long-lasting immunity. The estimates are really quite varied. Probably it's at least 10 to 20 years, maybe longer. But it might wane at about 1.3% a year. The vaccine efficacy as post-exposure prophylaxis is also pretty good. It's 50%. You might not think that's good, but that was actually enough to eradicate smallpox. So India was the last stronghold of smallpox, and they couldn't do mass vaccination there for various reasons, and they switched and developed this strategy called ring vaccination, which is essentially contact tracing and vaccinating the contacts, and that was adequate to eradicate it. Vaccines are based on the Vaccinia virus, and the first and second generation vaccines are replicating Vaccinia virus. The third generation vaccines are non-replicating, such as the MVA-BN, or replication deficient, like the LC16 from Japan. The first generation are basically grown in calf skin, so they've got impurities in them, whereas the ACAM 2000 is grown using cell culture, so it's not got those impurities, but the side effect profile is very similar. The WHO estimates there's about 700 million doses in the world today, mostly first and second generation vaccines. So the reason we're not rushing out to vaccinate everyone with ACAM 2000 is the side effect profile really is quite serious. There's myocarditis or pericarditis in 1 in 175, eczema vaccinatum, which is a disseminated, often fatal syndrome, and disseminated vaccinia in immunosuppressed people. So it's contraindicated in immunosuppressed people or people with any eruptive skin disorder. The first and second gen vaccines are given with a bifurcated needle using a scratch technique. You only need one dose, and the presence of a scar tells you it's been successful. It's called a take. You can't use that to assess the MVA-BN because that's a different vaccine. It's given subcutaneously in 2 doses and doesn't typically leave a permanent scar. Diagnosis can be done by electron microscopy. You see these brick-shaped viruses, although that doesn't differentiate unless you use particular stains. You can use PCR that can be generic for orthopoxviruses or more specific for variola or non-variola, and viral culture. There are treatments. The Vaccinia immunoglobulin is obviously a blood product, so in short supply. Cidofovir and brincidofovir. Brincidofovir is a bioavailable analog that doesn't cause the renal toxicity. And then there's the T-Pox, which is the first drug to be approved for the treatment of smallpox and also monkeypox. And of course, because smallpox is eradicated, the evidence for T-Pox, for example, has come from experimental and animal studies through the animal rule, as well as human case reports, of which there's several for different orthopoxvirus infections like cowpox, vaccinia, and combination drugs or single drugs used. So since 2013, we've noticed the incidence of monkeypox is increasing, also cowpox, and probably this is related to waning immunity from the vaccines. Monkeypox was first, or MPX, first detected in humans in 1970, but in animals in the 50s. Zoonotic transmission from rodents, but also other animals, but you can get human-to-human spread. Clinical syndrome is similar to smallpox, but it's less severe, and you do get this lymphadenopathy that's quite prominent. Smallpox vaccination was estimated to be 85% effective in a study done in the 1980s, but because that would have incorporated background immunity to vaccinia and smallpox, it could be quite a bit lower today. In 2003, the first outbreak outside of the African continent occurred in the US through imported rodents that then infected prairie dogs in the US, and they then infected humans. And then in 2017, we saw this resurgent epidemic in Nigeria. Now, Nigeria had not seen monkeypox for 40 years, and suddenly they were seeing hundreds of cases in 2017. There started to be imported cases in the UK in 2018, and then in Singapore and Israel in 2019. And these huge outbreaks with thousands of cases in DRC and also the Central African Republic. So briefly, epidemiology in the African continent is that usually it's in children. It was the median age was 4 to 5 years old in the 70s and 80s, but has got older to 10 to 21 in the 2000s, and probably 20 to 30 now. And it just reflects the aging cohorts that never got vaccinated against smallpox. Incubation 5 to 21 days. And the incidence has also been rising in this study from 2001 to 2013. The secondary attack rate in households ranges in different studies, but there's been at least 2 or 3 studies that show an attack rate of 50% in household contacts. Previously, the transmission was 75% zoonotic, 25% human to human, but in the 2017 Nigerian epidemic, 63% had an unknown source. Clinically, the lymphadenopathy is quite prominent, and then you get rash on the palms, soles, face, etc., and 30% have genital lesions. And the complications include skin infections, pneumonia, and ocular complications. In terms of the case fatality from monkeypox, the Clade 1, which was the Central African clade, it's been renamed, is the more severe one, 10.6%, and then Clade 2, which is the ancestor of the current outbreak strain, 3.6%. In the 70s and 80s, 100% of deaths were in children under 10. And in the last 20 years, though, only less than 40% of deaths have been in children under 10. And that again reflects the aging of the cohorts that were never vaccinated against smallpox. That just shows the huge increase in monkeypox since 2017. And this is a study we did trying to explain why Nigeria was seeing these resurgent epidemics of monkeypox. And it's basically 2 factors. One, the proportion of the population that's ever been vaccinated has gradually been decreasing. And 2, the people who were vaccinated have waning immunity. So that accounts for the overall population immunity declining from 65% in 1970 to 2.2% in 2018. And that appears to be the threshold where this huge resurgence was seen. So just to finish up, the main public health challenges are that, it's estimated that less than 20% of contacts are able to be identified now, when contact tracing is actually hugely effective. You can control an epidemic of an orthopoxvirus infection with really rigorous contact tracing and case isolation. Vaccine supply is limited. That we're now starting to see local transmission. From reports I've heard, half the local cases in Victoria are locally transmitted, and 1 in New South Wales today, since reported yesterday. We're concerned about spread to children and the immunosuppressed, who have more severe outcomes, including death. We don't want it getting established in animal hosts in Australia, because then we'll be living with it forever. And lastly, there's just some very concerning genetic mutations which are good to reflect on. So the yellow here is Clade 1, which was previously the Central African clade. The orange is Clade 2, and these authors have called this Clade 3, but it's actually the WHO has called it 2B. So Clade 2B is our current outbreak strain, and what it shows firstly, and panel B and C are just updated sequences, B up to May and C up to June, and including June, shows quite a lot of genetic diversity in the outbreak. And what it shows is basically continuous accelerated evolution of this virus and signs of adaptation, human adaptation, and ongoing microevolution. I think that is concerning. What does that mean? Is it going to become more transmissible between humans? Is it going to, I think the signs are it could keep changing unless we control it really aggressively. There are signs in the UK that it's plateauing, and in Europe, but I think a very precautionary approach given these genetic changes is warranted. Thank you.
Thank you very much, Raina. Our next speaker is Professor Andrew Grulich, who's head of the HIV Epidemiology and Prevention Program at the Kirby Institute. Andrew is an internationally renowned authority in the transmission and prevention of HIV and sexually transmitted infections and in the epidemiological relationship between immune deficiency, infection, and cancer. Thank you, Andrew.
Thank you, Miles, and I'm coming to you today from Bedigal land. And to start with, I have no relevant conflict of interests today. Very quickly in the next 15 minutes, I'll endeavour to cover clinical features of the newly emergent monkeypox, some stuff on epidemic trends, transmission and prevention, and just touch on treatment. So to start with clinical features, what we know about this has largely come from a couple of very large-scale clinical case series published in the last month or so in the New England Journal and Lancet, a total of about 700 cases. And you'll see they're really quite consistent with each other in showing that, 95 to 100% of cases in males, of those, well over 90% in homosexual or bisexual men, about 40% of them are HIV positive. Of the HIV negative, nearly 60% taking PrEP, highly sexually active with a median of 5 or so partners in the last 3 months. Concomitant sexually transmitted infections quite common, and a median age in the 30s. In terms of the clinical presentation of these conditions, we are seeing some quite marked differences from the monkeypox classically seen in West and Central Africa. So while almost everybody gets a rash, the really notable thing is that the lesions are much more likely to be in the anogenital region, about 75%. In the largest of these two studies, 70% of people had only one site and 10% had only one ulcer. So in many cases, it can be a relatively mild disease. Also lesions on the face and the limbs, a real variety in lesion number, but with only in the order of 10% having more than 20 lesions. Fever is common, lymphadenopathy, as Raina mentioned, tiredness, and a proctitis syndrome, which is one of the more clinically severe aspects, which causes very, very severe pain, which in some people requires hospital admission for pain relief. Sorry about the graphic photos, but this is the nature of the condition, and a variety of lesions on a variety of sites shown to you there. Diagnosis is by PCR swab, taking a swab and testing it using the PCR technique of this, usually of the skin lesion. And positivity lesions, rates of those lesions are close to 100%. In people who only have 1 or 2 lesions or who might be at high risk and who don't actually have a lesion, throat or anal swabs can be useful because they have a relatively high positivity rate. There is this question of whether people can be asymptomatic, and there have been 2 instructive studies here, but it is important to note that this definition between asymptomatic disease and mild disease is difficult, particularly when one considers that the anogenital region is a common area where 1 or 2 lesions might happen and might be missed. Nevertheless, studies in Belgium and France of specimens taken for STI screening, anal swabs taken for STI screenings, have identified a low prevalence of men with asymptomatic disease, about 1% in Belgium and as much as 6% in France. And these were men who were confirmed not to have monkeypox symptoms at the time the lesion was taken. And in the French case, they did have longitudinal data showing that only a minority later developed monkeypox. And at least in 2 of these cases, monkeypox could be cultured from these anal swabs of anal symptomatic men, suggesting potentially that asymptomatic people could spread this disease. Onto the epidemiology. There's been a lot happening over the last 3 months. So there's firstly this global map that the small circles of blue are the number of cases in those countries where we've known about monkeypox for decades, and the orange circles, the much larger ones, the case counts pretty much around the world now. The slope of this curve, and this is a logarithmic curve here, is gradually the rate of increase is slowing, showing that the number of cases, or the rate of the increase is slowing. One of the best sources of information on epidemic spread comes from the series of epidemic updates published out of the UK. And I'd really recommend this to anyone who wants to understand the epidemiology of this condition. So based on about 3,000 cases, they're seeing a median age in the mid-90s, almost all male, and quite extraordinary gender pattern here that of the very few women, so around about 1% of women, close to 40% of those women are transgender women. There have been 8 cases where they think that household transmission has occurred. So it occurs, but it has been very uncommon thus far. Enhanced surveillance data are available on about a third of these people, and these show that 97% of them are gay, bisexual, and other men who have sex with men. About a third are HIV positive, and of the negative, 80% had used PrEP, reflecting that they're likely having numbers of sexual partner. No confirmed cases of airborne transmission, and I think this is actually quite remarkable when we consider that this disease emerged after massive pride celebrations in Europe, where we have dance parties attended by 20,000 or more people. We have dance floors which are shared by the gay men who turned out to have this disease and by others, and yet we are not seeing transmission to large numbers of those other people at all, very small numbers in fact. In the UK, there have been no deaths and about 33,000 vaccine doses. And interestingly, just in the last month, we have started to see the epidemic decline. These are early data, and I don't want to overemphasize this, but they are seen in a number of geographical locations. I would ignore the last couple of weeks because that may well be reporting delayed, but we've certainly seen flattening, and it looks like we're seeing a decline in the UK at the moment. These data collected across the period of the epidemic convincingly show that the epidemic remains concentrated very much in highly sexually active gay, bisexual men who have sex with men. Over time, these indices have just remained the same. And this suggests that transmission is very much being maintained as largely in sexual settings and is not increasingly occurring in other groups or in other settings. So very quickly, in Europe, we see a very wide distribution now with most cases in Spain and Germany, the same patterns. And this is remarkably similar across countries, 99% male, very few admitted to hospital. Now, plenty of healthcare workers in this, but of course, being a healthcare worker is a very common occupation in society. Not a single confirmed occupational transmission in these data. And again, these are the overall EU area where we've seen a plateau and beginning to see a decline, and particularly in those countries which initially had the highest numbers. In the US, we see very similar patterns, largely confined to males, and unfortunately quite concentrated in racial and ethnic minorities and Black and Hispanic people. And again, we see a plateau with a suggestion of a potential decline, although it's more recent in the US, and I wouldn't be too certain about the decline. New York City, which did get the virus earlier than much of the rest of the US, would more convincingly see a decline. And this pattern, again, that trans people actually outnumber women. And I think this speaks to the sexual connectedness of these communities. It's very, very uncommon that in a general population sample, I mean, this is whole of population, that we would see more trans people than we see women. And I should just point out for the trans people watching that I do apologize for the variety of way that trans data are reported here. I'm simply passing on the way these data are reported in the data sources. In Australia, Monkeypox has been declared a communicable disease incidence of national significance. As of August the 18th, we had 89 cases, roughly equal numbers in Victoria, New South Wales, and smaller number elsewhere. And as Miles pointed out, we had local transmission confirmed over the weekend with considerable numbers in Victoria. So on to transmission and prevention. The Communicable Diseases Network of Australia, or CDNA, has put out guidelines about this, stating that the mode of transmission is through contact with the virus from an infectious animal, or not in Australia, but elsewhere it is, or human, or fomites, so things like bed sheets, like towels, occurs through broken skin, so not intact skin, or with mucous membranes. It certainly theoretically can be spread by respiratory droplets in prolonged face-to-face contact, so large respiratory droplets. And CDNA states that it's unclear whether the virus can be transmitted through semen or vaginal fluids. The incubation period is 5 to 21 days. There are some pretty convincing case reports now that with mucosal sexual exposure, the incubation period can be even shorter than 5 days. The infectious period is from the onset of symptoms until the rash is fully resolved. And so, as Raina mentioned, we generally say that's until the lesions have scabbed, the scabs have fallen off and fresh skin is visible beneath. That usually lasts 2 to 4 weeks. What about sexual transmission, which appears to be driving this current epidemic? So convincing case reports of people who have had only one sexual partner in the relevant time period, that skin lesions occur at the point of sexual contact. So, for example, around the mouth of people who report receptive oral sex, etc. Among MSM with monkeypox in the large Spanish series, those who reported receptive anal sex were more likely to have rectal inflammation, proctitis. MPX DNA can be found in semen. In those studies that have looked at this, it usually is found in semen. And again, there's limited data now, but certainly the studies that are available suggest it can be found up to 14 days after symptom onset. And 2 reports that this may well be replication competent monkeypox virus, suggesting that transmission can occur from semen and rectal fluids. And I would just make the case that really predominantly sexual transmission is the only explanation for why 98% of cases continue to occur in gay, bisexual and other men who have sex with men 3 months into the epidemic. And it's not declining, it's staying at that 98%. And I think one thing we should ask ourselves is that if virtually all transmission is sexual, can we then decrease the requirement for isolation of people who have been diagnosed with monkeypox? Routine prevention activities recommended by CDNA are self-isolation from other people and animals. This is important. We have had a confirmed case of transmission to a dog. And as Raina mentioned, the establishment of an animal reservoir is absolutely something that's critical. And based on the DNA evidence, but it's slim evidence at the moment, condom use during sex for a further 8 weeks is recommended, and that we need more data to really firm up that recommendation. Based on the previous knowledge of monkeypox, it has been recommended that carers should recommend gloves and a surgical mask, practice good hand hygiene, and avoid exposure to body fluids, lesion material, or contaminated materials such as bedding and towels. And then with people at high risk, to reduce the risk, condom risk is recommended. But there is the potential for skin-on-skin contact with an infected person to lead to transmission. With testing, PPE should be worn while collecting samples. The acceptable sample types include the lesion fluid, tissue, lesion crust, or even a skin biopsy, although that would be rarely required. Samples from more than one lesion where possible, and it's a simple dry sterile swab, no transport medium required. So it's quite simple from that point of view. So onto vaccination. Australia's Technical Group on Immunization, ATAGI, released this guidance on the 26th of July. This new generation of smallpox vaccine, which is actually licensed in many countries against monkeypox as well, called MVA-BN or Jynneos. It's been proven to be equally immunogenic against smallpox compared to the previous generation of smallpox vaccines. But of course, no vaccine studies against clinical disease because smallpox doesn't exist as a disease at this moment. And it does, protection against disease does occur in primates against monkeypox challenge. As you've heard, the supplies are very limited at the moment. It's replication deficient, which means we can use it in people with immune deficiency, and the recommended dosage is 2 doses by subcutaneous injection at a spacing of 28 days. It can be given after exposure, where it will likely be less effective, but up to 14 days is said to be still worthwhile. So the key risk groups recommended by ATAGI are recent contact, being a gay, bisexual, and other men who have sex with men, sex workers who might have clients in these groups, or in one of these risk groups and traveling to somewhere with a significant outbreak. Given the shortages, we do acknowledge that we need to look at ways of spreading the dose out. So one of the ways of doing this is to give only 1 dose or delaying the 2nd dose. There is a bit of an issue with this. In these data, which were recently presented at a WHO monkeypox vaccine research seminar, you'll see that at 4 weeks after the first vaccine, so before receiving the 2nd, the geometric mean titer is much greater in the older smallpox vaccine, ACAM 2000, than with the new one, MVABN. So it's not as immunogenic as ACAM 2000 at 4 weeks, and only after the 2nd dose, which you get at the 4-week visit, does it become very highly immunogenic. So it is less immunogenic compared to 2 doses. However, the very old Dryvax vaccine, the initial vaccine against smallpox, did have some efficacy within the first 2 weeks of vaccination, but that was a live vaccine. And 1 dose of Jynneos in the non-human primate model does protect against mortality and decrease lesion count. Another way forward that has been suggested is that you could give this as an intradermal dose. So this is in the very superficial layer of the skin, which contains very high concentrations of immune surveillance cells. In this study, which I'll explain to you in a moment, they gave only 1/5 of the dose spaced by 28 days, and compared it to the standard subcutaneous dose. So if we look at these 2 columns only, the subcutaneous and the intradermal, you'll see that the peak vaccination titers were very similar in the 2 groups. So this theoretically could increase the number of people you vaccinate by 5-fold. It does have some downsides. It is not as easy to administer. There's not many people who are trained currently in intradermal vaccine administration, and it is associated with increased hardness and redness of the skin. So just to give you a pictorial view of that, most of us are familiar with intramuscular. That's what all of us got for COVID. You just plunge the needle in as deeply to reach the muscle. The subcutaneous is what's recommended. You pinch some skin so that there's no muscle in that layer that you're injecting into the subcutaneous fat. In contrast, intradermal is very superficial, and you can see it's quite easy to get that wrong by going too deep or to inject out the other side. The pictures there on the top left, you see what that looks like it's given in the forearm. You see what that's like immediately afterwards. A bleb should appear, and then next to it, some redness the day after. The Twitter being what it is, it's already showing examples of what can happen with highly reactive red lesions, which can last for weeks. So it is a somewhat more reactive site. Last few slides, I'm conscious I've gone a minute or 2 over, but I'll just try to wrap up. So given that this would be a new way of approaching this, it would be really critical we would monitor vaccine efficacy. And I'll just go through a couple of ways we could do this. We could do this through case control studies where we compare the past vaccine history of people with monkeypox with controls. The problem with this is that it really can give a biased estimate of vaccine efficacy if there are differences in the ways that we sample cases and controls. So, for example, and this is likely to be the case, if people with more sexual partners are more likely to be vaccinated, the result on vaccine efficacy we would get would be an underestimation of what it truly should be. A slightly better design is to have a cohort or follow-up study where we analyse monkeypox rates in people who have not yet been vaccinated or yet completed their course compared to those who have been vaccinated. And if you collect detailed data prospectively on behaviour, you can give an estimate of vaccine efficacy that's adjusted for those differences in behaviour. Traditionally, cohorts have been expensive and not quick to set up, but we can now do this using virtual cohort designs, which are much quicker. Of course, the preference is to do a randomized trial. This would not be placebo-controlled because we know that the vaccine is going to work. Some suggestions have been that we could randomize people from a wait list. If the vaccine supply is inadequate, you could randomize men to initial vaccine to initial wait, and then the people randomized to wait would then be vaccinated when the supply allows. And you compare incidence of disease in those vaccinated to those unvaccinated periods. And then the people change over those groups. This is logistically pretty challenging during an emergency, however. Something that's more pragmatic is that you could randomize clinics to receive different types of vaccine, such as some clinics doing everybody with subcutaneous versus some clinics doing everybody with intradermal. It's much more likely to be pragmatic. So just one slide on treatment. Monkeypox is generally a self-limited infection. Most people do not require specific antivirals. However, management of the complications is required. The cellulitis can happen around the lesions and needing antibiotics and pain relief, particularly for that rectal syndrome. Tecovirimat is the preferred antiviral for severe monkeypox virus and is only to be initiated in Australia in consultation with an infectious disease physician or a sexual health physician. Only for really very severe disease or people at high risk, people younger than 8, immunocompromised people, pregnant women, and other complications. So finally, of course, we finished with the conclusion slides, but it is very early to be making conclusions about monkeypox. I would say that this remarkable and stable concentration in highly sexually active gay, bisexual, and other men who have sex with men does suggest, very strong, more than suggest, it demonstrates sexual transmission. And the very limited transmission to others suggests the aerosol spread is rare, even in places where you would expect it, like crowded dance floors. And the very close contact that happens in these big festival events on dance floors with a lack of transmission to people other than MSM suggests that even very close contact is not high risk. There is the beginnings of a suggestion that the epidemic may have peaked in terms of numbers in Northern Europe. That is by no means a suggestion that it's in any way over. It will likely reach a lower plateau until we get high levels of vaccine rollout. And really, we do need to look carefully and urgently at these innovative approaches to dose sparing to increase vaccination coverage. Thank you, and I'll hand back to Miles.
Thank you very much, Andrew. Now, I'll just also, before we move on to the next speaker, remind the audience that they can put questions in the Q&A, and also they can vote for questions they'd like to hear answered by the panel after the next speaker. So it's my great pleasure to introduce Mr. Heath Painter. He's the Deputy CEO of the Australian Federation of AIDS Organisation. His professional background includes more than 13 years experience working as a lawyer and in public health policy, providing advice on human rights and preventive health, focusing on community health and systems, strengthening cancer control, sexual health, HIV, and other bloodborne viruses. Through this work, he continually collaborates with community and consumer agencies to ensure the treatment and care needs of healthcare users are considered in decision-making. Welcome, Heath.
Thanks, Miles, and thanks for the introduction. I'm coming to you today, like the other two speakers, from Gadigal country here in Sydney. Can I just acknowledge the Kirby Institute's long-standing relationship with my organisation, AFAO, through HIV, and I suspect into the future on this health threat, and just thank the Kirby for the invitation, particularly Andrew for the invitation to talk to you all today. As Miles said, I'm not a researcher, I'm not a clinician, I'm a gay man working in Australia's HIV response, and I'm going to step you through why our community response to HIV is taking an active position in the response to monkeypox in Australia. In my presentation today, I want to show why there is a community response to MPX. I want to provide an update on the work of HIV and LGBTIQ community organisations to lead community responses to MPX. And I just want to highlight at the end some of the key issues AFAO and our members are working through to support gay and bisexual men navigate this emerging public health threat. Firstly, the name, and I promised that I would touch on this. The name monkeypox is far from ideal. Should it have been changed earlier? Probably. But how do you prioritise changing a name in the middle of a public health crisis? The WHO is responsible, or the World Health Organization is responsible for changing the name of monkeypox, and we will take their lead when and if they do that, but it's not for AFAO or ASHM or any other body in Australia to rename this condition. I will say we are using monkeypox for all forward-facing communication, so media and health promotion to communities, and MPX to the sector. We're not using MPX forward-facing because we risk confusing consumers and community members with names they may not be familiar with. So why is there a community response to monkeypox? Well, put simply, as Andrew said, the virus is circulating among interconnected sexual networks of gay and bisexual men, mostly at this stage in the Northern Hemisphere, but as we are seeing in recent days, also here in Australia. In Melbourne and Sydney. And so what is AFAO's interest in the MPX response in Australia? Well, AFAO was formed in 1987 by the CEOs of our state-based member organisations, historically known as the AIDS Councils. And we were formed to be a voice in Canberra for issues relating to gay and bisexual men in response to the early days of the AIDS crisis. And we coordinate action, health promotion and policy development and political advocacy to support communities through that challenging period. And we're again doing that throughout the early stages of this emerging health threat. What is it that brings AFAO to this situation? Well, clinically, as we know, HIV and MPX are very different. But our work in HIV and the knowledge that we have on the concentration of transmission of MPX among gay and bisexual men places us at the centre of being a trusted voice to advocate on behalf of communities to Canberra and to other governments, but also to work with communities to build their knowledge of this virus and also of the vaccine as we step into the vaccine rollout. And of course, our members have a long-standing association with the populations we work with, particularly gay and bisexual men. And I note that in the next week, our two largest members in Victoria and New South Wales, Thorn Harbour Health and ACON, are running community forums like this, but not to a research audience, but to a community audience, working with communities to build their knowledge of monkeypox. So serving our community's needs, what have our members been doing across the last 3 months? Well, we've been rapidly scaling up information to communities, led particularly by ACON and Thorn Harbour Health, to raise awareness of MPX and to build trust in the vaccine. And funding is coming from the Commonwealth to initiate further and larger scale health promotion in the near future to really reinforce messaging around monkeypox. We've had ongoing engagement with departments of health across Australia, both state and territory and federal departments of health. We've been heavily involved in the vaccine procurement process, and not leading on the procurement, but advocating for vaccine procurement, and also for advocating for a rapid rollout of vaccines, and in particular advocacy for vaccine eligibility guidelines from ATAGI. Weekly meetings with bloodborne virus and STI representatives from state and territory governments across Australia, led by the Deputy CMO. And we've also recently developed a national MPX task force, and I'll come back to this shortly. We've also been heavily engaged with ASHM in building the capacity of the clinical workforce to respond to this health crisis in primary and tertiary settings. And I want to acknowledge the great collaboration that we've had with ASHM over the last 3 months, and that organisation's steel in working with us to get what we think is a very good vaccine order to address monkeypox. So the key messages that we are delivering to community at the moment, and I want to stress that these messages are developed in the context of the current epidemiological profile of monkeypox, and if the risk calculus changes and we have more community transmission, these messages may change. But right now, these are the messages that we are delivering through our members to communities. And that is, while this virus can affect anyone, it has only been detected among gay and bisexual men through sexual contact. Gay and bisexual men should monitor for symptoms and seek immediate medical assistance if symptoms, particularly rashes and sores, appear. Those who have sexual partners in settings with community transmission, so travellers, should abstain from sexual contact for a fortnight once they've returned from overseas to monitor for symptoms. And where community transmission has occurred, members should be aware of the risk of transmission and consider limiting sex to known sexual partners. And critically, on the vaccines, we, like ATAGI, we recommend and we really support vaccines for all sexually active gay and bisexual men. And just to go to the bottom one there, priority should be given to those people who are immunocompromised, travelling to settings with community transmission, and those who have regular sexual partners or have a history of a recent STI. And just the second one from the bottom there, and Andrew touched on this, which I think is a developing bit of advice that we are giving, and that is that some men may wish to use condoms, consider using condoms for receptive anal sex to reduce the risk of anal infection, and particularly things that are very discomforting like proctitis. The National MPX Task Force, we've developed a task force which will be co-led by AFAO and ASHM, so community and clinical workforces, and this will be a task force that will be comprised of clinical experts and community leaders and representative from NUTCHO. And it will be tasked with providing intelligence to government from community and clinical workforces, and to provide advice and guidance around the challenges that we're navigating. Like organisations like AFAO and ASHM have done across the course of the HIV epidemic, we'll seek as independent organisations, as civil society organisations, to broker solutions to challenges that are facing Australia in the context of this public health threat. This the task force will be also will be led or will be supported by two subcommittees, one community and one with representatives from the clinical workforce and also researchers. And the Kirby Institute will play a strong role in the delivery of one of those subcommittees. And Nick Medland, who's also from the Kirby Institute, and I will co-lead the National MPX Task Force. I just want to step into some of the issues that we're currently navigating as we work through and step through this through monkeypox, and in particular transmission and risk communication, cultural safety in primary and tertiary healthcare settings, isolation, vaccine supply, and stigma. To start with transition and risk communication, as we've heard from the last two speakers, this virus is contained in Australia. Wholly contained to gay and bisexual men, and we know that it's been transmitted through skin-to-skin contact. And skin-to-skin contact, particularly in the early days, was this term, this expression that was being thrown around to provide people with awareness of MPX risk. But I want to ask this question, how do you distinguish types of skin-to-skin contact in communications to illustrate high and low risk of transmission? And even a further question, what does skin-to-skin contact mean in the context of gay and bisexual men and MPX risk? And people who know anything about gay culture and venues that gay men frequent, limited clothing is often a cultural norm, and these settings are deeply embedded in gay culture. And of course, gay men are also very affectionate with each other, hugging and kissing to greet each other. And so I want to ask this question, how do we communicate the complexity of skin-to-skin contact with gay men? And I want to show, and something that our organisations have been working on very hard, is that communication with men needs to be honest and unambiguous. And we know this from our work in building the capacity of gay men to make informed decisions around their health from almost 4 decades work in HIV. And we know that gay men will look to trusted sources of information for guidance on how to navigate MPX, particularly when there is media commentary that is inconsistent or inflammatory. And the messaging needs to balance the tension between targeted communications and avoiding messaging that frames MPX as a gay disease. And the nuanced nature of this situation means messaging needs to be led by community organisations who are familiar with gay and bisexual men and trusted by the community to provide informed communications. And of course, messaging that isn't led by community leaders risks being non-credible, ineffective, and potentially stigmatising. And this is particularly important around conversations and advice around sex in an outbreak situation. Care in primary health settings. I think this is a really interesting area that we will have to work through as we have more cases. At the very core, we need gay and bisexual men to feel comfortable accessing healthcare services for testing, treatment, and vaccines. But I just want to sit with this idea of what it might mean for a gay or bisexual man to receive a diagnosis of MPX, particularly men who have experienced a diagnosis for HIV during the AIDS crisis, or indeed during the era of biomedical prevention. And even other members of our community who have experienced ongoing trauma from the anxiety associated with a possible HIV diagnosis or diagnosis with another STI. I also want to raise the issue of what does medical advice look like? Some men may feel very anxious having to go to a doctor to describe the symptoms they may have, which may indicate MPX infection. And what, if any, is there a role for telehealth in this process? And of course, also PPE, absolutely critical. But PPE, depending on the engagement with a consumer, should be proportionate to the risk of transmission. And I guess I'm particularly referring there to pharmacies, and we're not expecting people to be exposing themselves in pharmacies, but people who come in with potential sores on arms and faces, pharmacists viewing those through a Perspex screen with a face mask on is sufficient to manage the risk of any kind of transmission. Care in tertiary settings and cultural safety. We know from presentations that we've just had that many of the symptoms for MPX appear in the genital and anal areas of the body, sores and proctitis. These are very personal parts of the body for any man, but particularly for gay and bisexual men as they are used for pleasure and desire. And of course, sex is a very important part of the way gay and bisexual men socialise. And there's a level to that comment that is, or there's an aspect to that comment that is a generalisation, but there's a lot of veracity to that comment as well. And so symptomatic responses to MPX will be very distressing for a lot of gay and bisexual men, and they will be concerned about the impact that this will have on their well-being and on their ability to engage with other men. And so I think there's a really important question for ID physicians, nurses, and healthcare professionals in A&E settings and other settings who might be seeing people with acute infection with monkeypox. How can these healthcare professionals create safe spaces for gay and bi men to talk about the impact of MPX on parts of their body that are personal and that are central to the way they engage in pleasure and desire? And conversations healthcare professionals have with men recovering from acute MPX infection must be respectful of and not erase sexual identity. Isolation, this is something that I think we are going to have to give more consideration to as we see and we expect to see an increase in locally acquired cases. It seems to be something that's kind of blocked in the too hard box at the moment, but it will be necessary. And some of the key issues that I think we need to think through here is support for people who don't have access to sick leaves, like casual workers and consultants. But also employers will need to be particularly sympathetic to people who need extended periods of time away from work. And it may be the case that a gay man is having to disclose his sexuality and his infection with something like monkeypox for the first time to an employer who's demanding to know why they're needing multiple weeks away from work to recover from illness. And if isolation is not implemented sustainably, we risk driving members of the community away from health services for fear of being exposed to isolation, compromising the public health response to this threat. And of course, what we don't want to have is people self-diagnosing with monkeypox, in actual fact, running the risk of misdiagnosing themselves with another condition such as syphilis or HIV, which would be very challenging for their health. And so I want to ask this question: what does a sensible MPX isolation policy look like? Prevention and vaccine supply. Andrew's touched on this. The current supply is limited, with another tranche expected later this year, and a bigger tranche expected early in the new year. We need vaccines rapidly available in this country to help us navigate outbreaks. I think one of the interesting, perhaps riches we have, is that the legacy of 40 years of HIV health promotion has led to many gay and bisexual men actually engaging in really positive health-seeking behaviours. And these gay and bisexual men will want to do the right thing by their own health and the health of their community, and they'll volunteer early for vaccines. But I think as we only have small numbers available at the moment, and progressively a limited supply over the coming months, we need to ensure the vaccine rollout reaches those most at risk. And we actually need to look at engaging gay men in conversations to make them identify themselves as being at low risk, and to perhaps withhold coming forward for the benefit of other people who are at greater risk of infection. Last couple of slides, managing the risk of stigma. In one sense, I could give a whole presentation on stigma, but at another sense, this presentation is actually all about stigma. It's all about creating safe spaces for discussion to happen in the public domain, safe conversations to empower communities to make informed decisions, to seek medical advice, to create demand for vaccines, and to create a culturally safe environment for MPX dialogue to occur between community and within community, but across our national community, because while most of the community isn't at risk of MPX, everyone has a space to play in reducing the risk of stigma. And I just want to finish with this this slide. I spend a lot of time working on the advocacy for PrEP in Australia, and one of my anxieties was that we would experience considerable stigma against PrEP, and we avoided that for a range of reasons. But it is now my concern with something like monkeypox, that when we start seeing sores and images of people sick in Australia, that we may experience a situation where demeaning language is used towards our communities. And my fear is that it will be weaponised at some point in ways that are very harmful. And so I want to leave and finish this presentation by asking everyone to think about how we can call out disparaging and really derogatory behaviour in our community if and when it happens. I'll leave you with that thought, and thank you very much for listening to me today.
Thank you very much, Heath, and thanks to all of the speakers. I think they presented a very excellent summary of both the history of the current outbreak, what we know about the science of transmission and immunity at the moment, and also about empowering the affected community and optimizing the public health response. However, we're only 3 months into the epidemic, and I think many questions remain, and we've certainly received a lot of questions in the Q&A and also some before. I thought I might start out, there's a lot of questions around transmission, and I think that was, could I get the other presenters also to put their cameras back on? Questions around transmission, and I just noted down some of them to do with whether it might be airborne, to do with the risk from bedding, etc., in hotel rooms, the risk to healthcare workers, and whether it might be transmitted by waterborne means in a spa, for example. And I think this also relates to a question from Scott McGill of Ascham. Is it an STI, and should it be classified as such? And would that help our thinking around this? I'm not sure who would like to address this first.
I'm happy to have a go. You've bundled together a lot of questions there, Miles. So
well, I think they're all around transmission.
Yeah, sure. So look, I think we are, of course, very concerned about modes other than sexual transmission, given that we know what we know about monkeypox, and that in the African setting, there seems to be some limited transmission within households, although most of it is from animals. But it wouldn't be the first time that a virus was transmitted differently in African settings to high-income country settings. So, for example, hepatitis B is commonly transmitted in household settings among children in African settings. Whereas in high-income countries, it's predominantly a sexually transmitted infection or transmitted through blood. And the usual reason that's given for that is the high prevalence of skin lesions in African children, whether it's abrasions or infections or non-intact skin seems to be much more common. And perhaps that's part of it, that non-intact skin needs to be part of the equation. The other part is that the epidemiological context of the first gay pride celebrations for 3 years, there was a lot of pent-up celebration that needed to be happening, and monkeypox was there for the first time. And those celebrations happen in big cities with huge celebrations, often tens and tens of thousands, with one city followed next week by another city, followed by another city in the next week. And that is a fairly perfect context for the propagation of a sexually transmitted pathogen, or indeed a skin-to-skin. Having said all of that, it's remarkable how constant over the last 3 months, and it is only 3 months, that the transmission patterns have been entirely confirmed to gay and bisexual men. So that speaks against airborne transmission being at all common. It suggests it's rare, I'd say, because these dance floors are shared by tens of thousands of lesbians as well, and yet we're getting very few infections in women. We're seeing very little evidence of fomite, towels, bedding, etc., transmission, because again, they would be spread by sex. They wouldn't be concentrated in gay and bisexual men. So this is a condition which, for now, is very predominantly sexually transmitted.
Okay, thank you very much. Another question is, again, from online. Were there certain factors involved in this current outbreak that made it happen now and not previously? Perhaps Raina might address that.
I think there's still a lot of questions about this outbreak. It really is unusual. The way it started, it's clearly spread through socially connected networks of men who have sex with men, initially in Europe. And I think the main thing is we don't quite know what the phenotypic expressions of the mutations in the virus are. We know that this is now called Clade 2b. It's different from the dominant clades in the African continent, but we don't know what all those mutations mean. We do know that the genital, often there are lesions at the site of sexual contact. So whether the mutations are responsible for some change in the mode of transmission, it's likely. I'd say that although it looks like it's being transmitted sexually and through close, intimate contact, I'm still concerned about the mutations in the virus and the evidence that it's continuing to mutate and adapt to humans, and what that means in terms of, I think we shouldn't be complacent, and we need to be quite aggressive in trying to control this outbreak.
Okay, I guess there's also a question from Mary Ward about the particular situation in Australia and whether we might be expecting a later peak than other countries, for example, in summer, and whether the majority of infections you feel will remain imported or become locally transmitted. I'll throw that open to whoever would like to take it on.
Yeah, look, I think part of the reason why the monkeypox has been relatively slow to take off in Australia has been to do with the fact that it's winter, that there are limited opportunities for skin-to-skin contact compared to a summer with mass gatherings. So it may be that come summer there will be more exposure, and it certainly points to the need to try to get vaccine coverage as high as we can before summer.
Any other comments? There are also a number of questions, I guess, about transmission in the region and transmission globally, and Australia's, I guess, international responsibilities to assist in other countries. Not sure if there's any.
Miles, can I just add to what Andrew said just before we get into go to the international aspect, that I think we should expect that there will be more locally acquired cases in Australia. I agree with Andrew about the reasons why we may not have seen that so far. I think we've probably had, you know, an amazing level of skill with our doctors and clinicians who've been able to identify MPX, but also really hypervigilant gay men who've identified symptoms early and gone to see very skilled GPs who are informed about MPX. I also think we had our borders closed for a long time with COVID, and they reopened during the onset of the colder parts of the year. And I think we'll see a lot of travellers, overseas travellers, not local travellers who've gone overseas and coming back, but overseas people coming to Australia who may bring this to Australia as we head into summer. And so I think Australia should be prepared for an increase, and perhaps a fairly sizable increase in locally acquired transmission.
Okay. I guess there's a number of questions as well that have come up around who should get vaccinated. And I guess there's two questions. Who should get vaccinated if we had infinite vaccine, and how do we prioritize the distribution of the limited supplies that we have? I'm not sure if anyone would like to take that on.
I'm happy to start if the other two are more than happy. Well, I think we need to prioritise travellers who are going to settings with community cases of MPX. I also think we need to prioritise people who are immunocompromised, and particularly people with HIV who, for whatever reason, are not on treatment or have unstable use of treatment. And I know those numbers are small, but there are a couple of really severe cases of people in Europe who have acquired monkeypox who had low CD4 count. And again, those numbers are small in Australia, but they should be immediately prioritised for the vaccines. And I think once we address travellers and immunocompromised, we need to look at people who have multiple sexual partners, particularly casual partners, and people who have a recent history of STIs. And we actually can get a lot of access to those people through some of the databases we have in healthcare systems. The question of infinite supply is actually not going to happen for the time being. So I think it's pretty academic.
Did anyone else have comments?
I'd just say, Miles, that with the numbers that he presented in his presentation, that tends to suggest that we will not have adequate vaccine to get high vaccine coverage among the people who most need it with this first slice of vaccination. And so I think, therefore, it does really behoove us to really look in detail at these dose-sparing strategies and whether we should be using them. In the US, the Food and Drug Administration approved the intradermal dose-sparing regimen just last week. And I think we should be seriously thinking about it. If we do it, it's quite logistically challenging because we have to train the workforce in giving the vaccine intradermally. And we would really need to set up monitoring systems to monitor the effectiveness of it. You know, this is proven in one study to be immunogenic from the point of view of immunogenicity to be equivalent to the subcutaneous route, but we really would need to monitor whether it provides equal clinical protection.
Okay, thank you. On a sort of slightly different note, there's a question, what are the estimates of viral survival on bedding, furniture, plates, etc.? Raina, perhaps you'd like to comment.
There's not that much data on monkeypox, but I would assume it's similar to smallpox being an orthopoxvirus. And with the smallpox, there was one study in particular that showed that it could last decades, like decades in a scab, if there's protein matrix and the material is not exposed to ultraviolet light, it can survive a long time. But these viruses are very can be killed easily with disinfectants. And
I guess it's probably worth saying that in the current epidemic, we don't really have evidence of that sort of transmission from surfaces or bedding. So I guess viral survival versus transmission might be two different things potentially.
Yeah.
And another question that Andrew might like to answer, others. What's the thinking about why there's been the potential plateau and perhaps slight decline in Europe? What are the factors around that we could learn from?
So first thing to say is it's very early data, and we shouldn't, assume that it's going to continue. But I think the other thing to say is that there is not enough vaccine coverage in those populations for us to think that it is due to vaccination. That may play a role, but it's unlikely to be the primary role. So it's likely to be multifactorial. Gay men's behaviour has likely changed quite a lot since the beginning of this epidemic. The epidemic's been very highly publicised in Europe and US, and it's likely that behaviour has changed. I'm not aware of any scientific studies out there at the moment that have shown that, but they're 3 months into the epidemic, we need to look at whether that's happening.
Okay, I also realize Heath sidetracked me on my question about international responsibilities. And I brought back to mind perhaps by a question from Andrew Grulich, a member of the Kirby Institute. What should Papua New Guinea and other countries in our region be doing to enhance monkeypox surveillance at this point? And I guess I'd sort of add to that, and how might Australia assist in those responses?
So no surveillance will be possible without lab capacity, obviously, Miles. So we need to work with our partners in the region to ensure DNA testing becomes available. It was extraordinary the way that the COVID epidemic rapidly ramped up DNA-based testing around the world to places that barely had any of it beforehand. So we absolutely need to work with building lab capacity. Not directly an answer to the surveillance question, but we need to join the global effort to ensure that vaccine supply is increased. The third generation vaccine is manufactured by a small company based in Denmark, which is unlikely to be able to meet global demand from a couple of hundred countries in millions and millions of people. So if that company can't do it, we need to work out ways of urgently licensing that to be produced by companies that can, because that vaccine is going to be a critical part of the response to this, including in controlling the African epidemic. And we mustn't lose sight of that in this context, that Africa, unfortunately, has almost zero of these third generation vaccines and needs it to control their epidemics as well. Because as Raina pointed out elegantly, it's the declining immunity against smallpox because of the lack of vaccination for decades now that's allowed this to happen.
I might just add, in terms of surveillance, for low resource settings, wastewater surveillance is one option, because the monkeypox virus is found in the stool. And there are rapid tests and capabilities coming up soon for wastewater surveillance, so that kind of pool testing in communities to look for early signals, but also open source epidemic intelligence, as in our observatory EpiWatch. We've got a monkeypox watch happening, which is where we're looking at all rash and fever outbreaks, which could be other disease, misdiagnosed monkeypox. Things like hand, foot and mouth disease, varicella, etc., that have been misdiagnosed, but are actually monkeypox. So, there's other enhancements to surveillance that can be used in low resource settings.
Okay. Another one from Aaron is, what advice and support should be given to sex on premises venues to support reducing risk of transmission at these sites?
I'm happy to have a go at that one. This is very topical. I think SOPVs are absolutely critical sites for, or saunas or bathhouses as they're more commonly known in the community, are critical sites for authorities and healthcare workers and health promotion to reach the community affected. And so I want to start at that point, because closing them is not an appropriate approach, even in an outbreak. I think SOPVs need to look at QR codes and mandatory QR codes for people who access them. I think they also probably need to look at how they're cleaning the venues, how they wash towels, and whether the towels have been washed with the right detergent at the right heat. I don't know what that looks like, but I think these are the kinds of sanitation questions that they need to look at to ensure the places are as clean and safe as possible. But I think it starts with QR codes. And I also think they present as a great opportunity to roll out vaccines, to raise awareness through health promotion, and to be just generally part of the development of safe spaces for dialogue to occur on MPX.
Okay. Any other questions around or responses to that? Andrew, no. Another question is, what is the experience with vaccine in patients with low CD4 counts, and the correlates of protection for those people? Perhaps Andrew.
Yeah, Raina might have stuff to add to this, but the vaccine has been trialled in HIV positive people with CD4 counts of more than 200, and it seems to be immunogenic and safe in that group. In people with lower CD4 counts, there would be it hasn't been trialled, but there would be a concern that it would be less immunogenic because of the lower immunity. Because it's not a live virus, there should not be added safety concerns in that population. But the vaccine may not work as well in people with severe immune dysfunction.
Yeah, I'll just add that you'd want to think about ways to enhance immunogenicity, and that could include intradermal administration, for example, in people who are severely immunosuppressed. That's one thing to consider.
Okay. There's a couple of questions that have come up in the chat about the fact that gay and bisexual men who have sex with men are a fairly medically linked in communities. So the detection there is likely to be quite high. Might there be undetected cases in the general community who don't think they're at risk, and how? What should we be doing about that?
So I think the UK data are pretty clear that that doesn't seem to be happening, but we do need to ensure that people other than gay and bisexual men who believe they might have contracted monkeypox have a way forward to get tested with that. They're not going to get refused testing. And that's particularly in people who have some form of contact with gay and bisexual men. So absolutely, testing should not be restricted to gay and bisexual men, even though that's where we are going to find most cases. And we need to investigate thoroughly any cases that are occurring in people who don't fit that demographic. I think that's critical because, epidemics do change. This one is not showing signs of changing at the moment, but it doesn't mean it won't change in the future.
Okay. I guess as another question from Tiffany Walker that came earlier, what are our thoughts on therapeutics, drugs for monkeypox, and what their use will be?
I mean, there are effective antivirals as well as vaccinia immunoglobulin, but as I mentioned, the VIG is in short supply, so it really will be reserved for people who are seriously ill, not for regular, just, you wouldn't be using these antivirals or VIG widely because of, generally the infection seems to be self-limited in the current epidemic. So yeah, just for people who are severely ill. If you had unlimited supplies, you might think about it as post-exposure prophylaxis. That's one potential way to think about using antivirals.
Any other comments? Perhaps along similar lines to how we roll out limited supplies. As a question, what are the panelists' opinions about the reduced dose being administered in the US, and whether that's how that should translate here? And there's some other questions about if there are any updates from the original studies of intradermal versus subcutaneous immunization.
Raina, I know you were at a meeting which discussed that paper the other week. Did you want to add something about the Frey paper? Is there
Yeah, look, I think from a pragmatic sense, when there's a shortage of supply, you have to look at ways to extend the supply. You know, is it better to give more people a fractionated dose versus fewer people a full dose? Generally with vaccines on a population level, giving it to more people with, you know, either as a single dose or fractionated dose is going to give you more population protection, population benefit than giving it to fewer people. And I guess we also have to think about timing of major events that are coming up in Australia. I think there's an International Pride event in February and then Mardi Gras in March. So you don't want to miss the boat. You don't want to, you know, if you have to think about when the big exposures are going to be and utilize your vaccine in a smart way. So, you know, if you just said, oh, we're going to give, you know, the full dose to, you know, X number of people now, and, you know, we'll give them their second dose, we'll space it out and give it to them in April. Well, that's you're going to miss the boat. You know, you may as well, you've got to think about the exposure risks and the epidemiology as well as when you've got limited supply to try and really optimize the protection. Over.
I guess it's worth saying as well, the fractionated dose subcutaneous at the moment, the evidence is that it gives the same immune response. Sorry, the fractionated dose intradermal, the evidence is it gives essentially the same immune response as the subcutaneous. So people aren't getting a sort of weaker vaccine. There's challenges around administering it, and there's potentially challenges around the local irritation being higher. But in terms of the immune response, the evidence is saying it's equivalent. Would that be correct, Andrew?
That's the data from the study. I mean, it's worth saying that these vaccines have not been directly trialed to prevent monkeypox in humans before. So we will be learning as we go. There's good reason to think that they will be highly effective, but, you know, we're going to find out in the next few months.
Okay, I think we're drawing towards the end of our time. I don't know if the panelists had any other comments they'd like to make or questions they'd like to answer.
I wouldn't mind having a go at one of Heath's, Miles. I think he had a question about the whole isolation thing. I think, you know, our current recommendation for isolating for 21 days was entirely reasonable when this epidemic began, because we were concerned about casual transmission of this virus. The way it's evolved into an almost entirely sexually transmitted condition, I think means that we should be thinking about changing our isolation requirements or adapting them so that people don't have to isolate at home for 3 weeks. It's a big ask of people. I think that's something, you know, I think perhaps we need a little more data over the next month or so. It's still very early days, but if the data continue to hold up that it's almost entirely sexually transmitted, then there doesn't seem to be a logical reason to be keeping people at home for 3 weeks.
One of the many questions we need more data on. But, okay, well, unless anyone has anything else, I'd like to thank all of the speakers for, I think, a very informative update. And hopefully we might come back and get further advances in future months as we learn more about infection and spread. So thank you to everyone.
Thank you. Bye.